No problem.
Thank you.
Okay, hi everyone. It is really nice to see you all and to meet you and to spend some time chatting about our efforts to try and improve treatment for patients with OUD. So I will give you a quick overview of who I am and Ophelia. I will also be joined by our Director of Clinical Services, Ryan Gallagher, in a few minutes. He's just hopping on momentarily. I'd love to then get a sense of who's here and have you guys introduce yourselves and sort of talk through what your role is and also your involvement working with our patient population, just so that we can really figure out how to be most useful for you and your teams. At the end of the day, my hope is that we're a resource for you guys. And so in order to make sure that we can be really effective, it's good to know what your issues are and how we can help with those. So a little bit of context about me first and how I got here. So I live in San Francisco and spent the last 8 years working for the San Francisco Department of Public Health, directing a CDC funded project that was really focused on working at the county level throughout California, working with counties that were really struggling to provide treatment options for patients with opiate use disorder. So counties that had really high overdose rates, really low buprenorphine access. And we just real quick, when I'm just going to let people in. I see I'm host now. Is that okay? Just as they come.
Absolutely.
Okay.
You have full control. I'm also letting people in too, so you don't.
Oh, good. I didn't know if that was just on me. I just felt like I was on a power trip. Just
you got it.
Away.
No, we've got you covered. Thank you, though.
So I spent about 5 years working at the county level with clinics that I think are probably quite similar to where you guys are. Trying to get providers to provide holistic treatment for patients with opiate use disorder. It was really, really challenging. And what we found was that, the pace at which providers were willing to come on board to get X waivered and then actually do something with that X waiver, providers just weren't moving fast enough for the need that we were seeing in these counties. And so we had demand from the patient side that just was not being met. And part of my transition to Ophelia was that I saw this really as a solution to work either in conjunction with county health departments and clinics, and also as a standalone option for patients. And so Ophelia is a fully remote telehealth clinic that offers medication-assisted treatment, largely buprenorphine. We're building out a suite of additional services like peer coaching and therapy, psychopharm, to treat opiate use disorder for patients and to provide them with sustainable long-term access to MAT. A lot of our patients come from these rural counties that I spent a lot of time working in. They're patients that have no access to a single X-favored provider in their county, or they have a few providers that are championing this issue, but those providers live far away from them, or there are all sorts of administrative hurdles and barriers that prevent them from seeking treatment. So we're sidestepping in some ways and giving patients access to come straight to us when they don't have those resources. And then what we're doing is also really working to connect patients back to care in their community. So a lot of patients, about 80% of patients, come to us disengaged from the medical community, which I think is crazy. Not just that they're not on MAT, but they're like not seeking treatment for, like, they're not going to their primary care visits. So we stabilize them, we get their use under control, and then we really go out of our way to connect them with champions in their community, either for additional, psych treatment, for managing their comorbidities, or just connecting them to primary care. So it's really important for us to talk to folks like you and figure out who's on the ground for these patients that we're helping to support, and how can we work together to help you guys and to help our patients. So that's sort of a quick overview, but I wanted mostly for you guys to know that I've spent most of my time really focused at the county level, focused on clinics and really trying to get providers to to be bought in to provide this treatment for patients. Ryan is going to go through a quick presentation on Ophelia and what we offer, just so that you guys have a good sense of what we can provide to you. And then I'd love to go through that quickly, spend the rest of our time really just in an informal setting, talking through exactly how we can work together. And maybe before, Ryan, if this is okay with you, before we even dive into the presentation, just to anchor us, maybe we could spend a few minutes having you guys introduce yourselves and then telling us a little bit about what some of the issues are that you're facing at the clinic level, providing bupe to patients, or just navigating and managing the overdose crisis that we're currently in. Yeah, so if we can maybe just run down the line and do some quick intros.
Well, it looks like we have a lot of people in the meeting.
A lot more have joined, actually.
Yeah, we have like 20 people. So introductions might take a long time, but maybe we could just do like popcorn style. I'm really curious to hear just the challenges you all are facing with opioid use disorder in your community, your clinic. And if you want to say something, just maybe briefly introduce yourself and your role in the clinic rather than introducing everyone.
Thank you. I thought we were still only 7 people. I hadn't scrolled.
We have a lot of people in the call.
Can you hear me?
Yes.
I'm Chris Dennehy. I'm the executive director of Child and Family Guidance and Addiction Service, and our clinics are called Step One. So we're an outpatient clinic, certified by the state, and we provide MAT services. We have our medical director is a psychiatrist, so we also can treat co-occurring disorders. Is that it? Are we just popcorning that, or can I ask a question?
No, however you want to do it.
How much popcorn am I allowed? Yeah.
We're just curious to hear kind of your experience in treating these.
Yeah. So, the telehealth has been very helpful, as a brief sort of Band-Aid to continue treatment and some sort of consistency. And then we definitely have clients that respond well to that. And then we have clients that don't. We have a lot of mandated clients as well. So, there's a tendency to try to do as little as possible and get away with as much as possible. And we're the only ones advocating for them to continue living without overdosing, kind of thing. So that's been like right now, my clinics were mostly remote, and groups on telehealth are quite challenging. So just that interpersonal connection, that face-to-face, we've been missing that. So, but we train all our staff, and then anybody being intaked is trained in, given Narcan kits, so, we're trying to hit it from every angle. I could keep talking.
Any other folks want to share before Ryan sort of goes into a quick presentation?
I missed out a little bit. I was had to step out. Are we doing introductions? I wasn't sure. I don't want to sound. Was that what you want?
Well, we're just wondering if you have experiences to share about what it's been like treating opioid use disorder in your clinic or your community, your impressions of the challenges that you face in your role in helping these patients, or the friction that your patients have with the system and the communities where you are.
Yeah, my name is Juliana. I work with Oracle, Opioid Responses County Law Enforcement at the Ulster County Sheriff's Office. We do have a lot of challenges we face with individuals struggling with substance use disorder. The major will be getting services, especially now in terms of medication management. Sometimes it's difficult to get people into those appointments quickly, because a lot of times there's a backlog of appointments. So we do have to go around different providers to get appointments. Sometimes also the bridge script as well. And sometimes, like we had a client today that missed a dose. So those kind of things happen, and it's really very hard to, especially at like 3 p.m. in the afternoon, to get somebody into those kind of programs, especially with COVID now. It makes things very, very difficult. And we have to basically beg to have some of these clients get the help they deserve.
Do you have any challenges with pharmacies in your community, kind of giving pushback about, buprenorphine, Suboxone treatment? No.
Generally, I would say that we do not, it's not necessarily the pharmacies, but our bridge scripting, as Juliana was saying, sometimes bridging the bridge, even, it's like the appointment might be 7 days out, but you were given a bridge script for 3 days. And so, we're, making it to that primary appointment, to see a doctor, to get, onto a program. So yes, and detox was mentioned as well. So detoxing, we are seeing a rise in fentanyl in our community, and we know that has, it's been an increased, it's definitely increased our overdose rate substantially. But we also know that there's some intricacies in terms of, detoxing, and as well as bridging on MOUD when it comes to fentanyl involved cases. And so those are the things. But I think getting fast access to treatment in psychiatry has always been a bit of a barrier, especially today with these workforce challenges.
Mm-hmm.
Why don't we run through our presentation? I think a lot of the challenges that you guys have put in the chat and that you've mentioned, particularly around, some of the operational barriers, access on weekends and evenings and transportation. I think a lot of those we can discuss ways in which we, as a, remote first clinic, can really hopefully help you guys not have to, as someone said, beg to be able to place patients into programs.
Great. Well, I will run through this pretty quickly. I'll try and keep it to 15 minutes or less. Feel free to interrupt me throughout. And I would love to keep the rest of the time for just more discussion and figuring out tangible ways that we might be able to help you guys. So just briefly who we are. This is our kind of leadership team. Emily's already introduced herself. My name is Ryan Gallagher. I'm our Director of Clinical Services. The main charter for my role is to expand the scope of the services that we offer to our patients. As Emily mentioned, increasingly, we're thinking of ourselves as a kind of medical home for patients with opioid use disorder. A lot of these people don't have primary care doctors, don't have psychiatrists, and yet they have many other medical comorbidities, psychiatric comorbidities, but they're not getting them treated. Their most burning need is Suboxone. They're in withdrawal. And so they come to us and they have a pretty clear need, and they build trust with us. And I think in some sense, we have a kind of captive audience of these patients, and we can be a wedge in order to kind of help them with other things in their lives, whether it's diabetes or hepatitis C or depression or anxiety. Increasingly, we want to expand the scope of services that we can help people with. More about me. I'm a physician by training in internal medicine. I don't practice anymore. I'm strictly on the business side of things, but I've worked in different startup environments in the past and in the mental health space. And the way we're thinking about these service expansions is either building it ourselves or partnering with other organizations that can offer them. This is our clinical team, but our clinical team several months ago. So we've grown probably twice as much as where we are here. And this is across 11 different states where we're licensed to treat patients. I don't need to kind of belabor these points. I think you all kind of already know this and shared your experience. We all know that this is a really costly problem that is compounding and in many ways getting worse, as evidenced by last year's numbers from the CDC, over 100,000 overdose deaths.
Hey, Ryan, sorry, could I jump in with a quick question really quick?
Yeah.
In terms of insurance, I know that you're probably going to get there, but what types of insurance do you take? Because we, for the most part, only take Medicaid, Medicare, and uninsured patients.
Yeah, great question. So we actually originally started as a direct-to-consumer platform. Patients were paying us $200 a month just for this treatment, and many of these patients were on Medicaid. And so in the last 6 months to a year, we have started to sign a number of insurance companies across the country. And we now accept insurance companies, and our providers are credentialed to treat patients who are on Medicaid in many states, not all, but we have insurance contracts that give us access to 75 million covered lives across the country. Of course, like the vast majority of patients with opioid use disorder are on Medicaid, so we can't ignore those insurance contracts. So maybe Emily can share more about kind of specifics, but the concentration of our insurance contracts are in New York State and Pennsylvania, and we're slowly signing contracts, both national and kind of regional contracts. Great. Well,
I'm sorry. I'm sorry. I think I missed it. Did you say, so right now you're not contracted with Medicaid in New York? We have a lot of Medicaid folks too.
Emily, do you know the specifics of?
Yeah, so we have some of our New York plans are both commercial and Medicare plans, and we are, I think, going live on February 1. We have a few additional plans to add to this, and so I can get those as Ryan's talking and fill them in. I just left in the chat the plans that we're currently active with. And for patients who are not covered by the plans that we currently have, we also do allow patients to pay out of pocket. So it's $195 a month, which for many of our patients is less than they're paying on the street for their medication. So it's an option for patients that would like to pay out of pocket.
So when you say Medicaid, is it straight Medicaid or Medicaid HMO?
Yeah, let me double check. Oops, sorry. What starts in February, and I will pop that in as Ryan's talking.
Thank you.
And so that $195 a month, one of the other questions that Victoria asked was, do you have a sliding scale for patients who maybe can't afford the $195 a month?
We don't at the moment, but we are building it out. We're coming up with a financial aid package so that I don't know exactly when we'll roll it out, but sometime soon we'll be able to offer that. I will say, even when we were complete out of pocket, 80% of our patients are Medicaid patients. That's always been our population. And so we have found that it is still substantially cheaper than what most patients are paying, either out of pocket on the street or from other providers that they're going to in person.
Okay. Again, the main backbone of our program is we offer medication-assisted treatment. Eventually, as we diversify the services we offer, we're launching peer coaching next month. We will be able to offer treatment to patients who aren't ready for medication-assisted treatment. And not all patients want to be on MAT long-term. And so right now, all patients at Ophelia are taking Suboxone because they meet diagnostic criteria for it and they want to. But I think some patients who are more tentative, we want to be able to offer treatment in other ways so that once they build a relationship with the company or with a peer coach, they might become amenable to MAT and then the door is open. But our general guiding philosophy of care is that we want to feel like a treatment program that is designed for individuals, not kind of a one-size-fits-all approach. And we want to feel different than the traditional experiences patients have had in clinics in the past, where they go and they've been going to the same clinic for 10 years and they still have to go to a group in order to receive their Suboxone. Or there's regular, urine drug screens, and if they test positive for marijuana, they get kicked out of the program. We are kind of philosophically harm reductionists. and yet we continue to do urine drug screens, but we understand that our patients are human, and that if, along the way they, have problems with use, we don't take a kind of punitive or paternalistic stance, but we're curious and we work with the patient to understand what are the barriers that are getting in the way of treatment and how can we support you. Of course, sometimes it reaches a certain point where patients can't get their use under control and we're not the appropriate treatment platform for them. But I think that we take an approach that is, to many patients, refreshingly humane compared to experiences that they've had in addiction treatment in the past. Again, we don't need to belabor much of this, but the problem really is that people have trouble accessing this. You all know many communities, many counties in the country don't even have an X-waiver provider. And there's a lot of programs out there that don't offer MAT and just aren't as effective. And patients in many cases want it, but they can't access it or they have long waits.
Ryan, you have a question in the chat from Katrina Williams.
Right.
Basically kind of goes back a little bit. Oh, Emily just answered.
Okay.
But the question is about the communities that you serve, and how do you learn each community? Do you have like a system? Yeah, how do you learn each community so that you can make those linkages?
Yeah, it's a great question. It's something that we need to become more sophisticated at as we grow. With the beginning of the company, we're a digital company, right? So most of our patients we find online. These are advertisements on Facebook and Google, and patients hear about us that way. And so until recently, we haven't really had to think about local communities as much, although our providers are talking to primary care doctors and engaging with psychiatrists on an as needed basis. Increasingly, we are realizing and talking to clinics and communities like your own that have a high need, and we want to be able to serve you. And the point that you're making, Katrina, is really good in that every community is unique in the services that are available to patients and the challenges that patients face.
Yeah, I will, just to add to that, our clinicians often come from communities that our patients come from. And so they've got a really good handle, not just on resources, but also like, what is the black market drug supply look like in Ulster County right now? And when you're seeing those upticks in fentanyl, we've got a lot of providers on the ground that know what's going on. And then we're building out a repository in-house of referrals, because even if we're getting patients from Facebook, we still need to refer them out to places. And so we have an internal list of partners that are really our valued, trusted partners that we know will provide the same quality care that we provide. And that's the first line that we go to when we refer patients out. And then we also have a list of other telehealth providers for those patients that are really doing well in a telehealth space and have a ton of barriers, transportation, childcare, jobs that don't let them go in person for other care. So we can also, refer them out to other like telepsych support groups as well. So we're building that out.
And it sounds like, and Leanne is saying she has a lot of individuals not interested in Suboxone because they feel like they're replacing one drug with the other. Some people are interested in Vivitrol, but this is a challenge because they can't abstain for long enough before starting. Yeah, we hear that quite a bit as well. I mean, I think that there are some common tropes and concerns and misconceptions. And I think part of how we increasingly think of our role in communities or even on online communities is kind of reshaping the narrative of how people think about medication-assisted treatment by providing education about it. So, right now we do not offer Vivitrol. We just offer Suboxone, and in very rare cases, when a patient's eligible, we offer Subutex. But we have discussed what the role of long-acting injectables would look like and how we might be able to do those kinds of treatments for patients who would meet criteria in the future. Medications like Sublocade for patients who have trouble with adherence. So as our company grows and expands and we can reach more patients, we want to be able to offer services that are more personalized for individual patient needs and their concerns. I'll just briefly go into kind of what our model looks like. Because we're virtual, we're able to overcome a lot of the barriers and frictions that patients face. Some of these barriers are geographic, some of them are stigma and privacy, others are, these people have jobs and they're not able to make it to a clinic that's, an hour and a half away. Whereas, when they're virtual, a lot of our patients will take their video appointments from their smartphone in their truck at like a construction job site. And they'll go to do their urine drug screen in the bathroom down the hall, right? As long as they're in a private space where they feel comfortable taking the visit, that's much better for a lot of people than having to drive a long distance to go to a clinic. And I think the last thing that's pretty unique is that we've been able to reach a lot of patients before they end up in the traditional healthcare system. I think there's a lot of people earlier in the stage of the kind of natural history of opioid use disorder that know they have a problem, but they haven't reached a point where they've ended up in an emergency department or a hospital yet, or even talked to a doctor about their concerns, but they feel comfortable kind of reaching out for help via online. When some, kind of day they see an advertisement that says, hey, are you struggling with opioids? There are some ways that we might be able to help. We've created a model that we call the Ophelia care model that makes use of a team of providers that extend the prescribing clinicians who have the X waiver. I'll let Emily talk about this because she played a really important role in designing this model, and she can kind of tell you how it works.
Sure, I'll run through it quickly, but if you guys want more information, we can talk about it in more detail. But essentially, we are offering an integrated team-based approach to the care that we provide to our patients. Part of that is to ensure that we have full coverage every day of the week and including evenings. And so I know this is an area that I think is a real pain point for brick and mortar clinics, where like, you guys turn the lights off and lock the door at some point. We have the ability to stay open late, to stay open on weekends. And so part of that is because every patient gets set up with a care team. And so they have a prescribing clinician, they have a supportive nurse, our nurse care manager, and then they have care coordination support as well to facilitate all of the administrative needs that they have to make all of their referrals, to make sure that they're showing up to their appointments, things like that. Because the workforce of X-waivered providers is so limited, we are really trying to allow people that are champions for our patient population, but they're working another job, they're a hospitalist, or they're, at an F2HC during the day, but they love working with OUD patients and they want a side panel. We allow those part-timers to join us. They give us a minimum of 8 hours a week. We got a lot of folks that just work 1 day a week. And because we have the supportive nurse to help manage their panel, they can come in and work for us on a Tuesday. And then when a patient has questions on a Wednesday, Thursday, or Friday, we can still provide them with that support so that they have access 7 days a week, no matter when their provider's working, because the nurse care managers are full-time with us, providing that additional support to our patients. So it allows us to provide really comprehensive care. And it also allows us to stay very close to the patients. So our care coordinators are really doubling down on the technology that we've created to stay in close contact with patients. So whereas in a brick and mortar, you'll see a patient when they come in, and then you'll see them the next time they come in. In the first 30 days of treatment for our patients, we have 160 points of communication with them, from texting and calling and seeing them. So especially during those, that induction period when there's points of clinical instability, we're able to really hold their hand and to anticipate issues that may arise, see them and catch them early so that we don't have to deal with the full relapse, but we can start to see those clinical signals early on because we're just in such close contact with them.
Great. I think Emily addressed some of this, but patients in our program kind of go through a progression of different types of visits. And as in any kind of treatment for opioid use disorder, in the early stages of care, patients are seen quite frequently during the induction period, weekly or twice a week in the first week. And then the first month it's weekly. And then over time, patient spaces out to biweekly and then monthly visits long-term once they're in a maintenance phase of treatment. We've developed, Emily alluded, we've developed our own technology, including our own electronic medical record that allows us to communicate internally and build this kind of care team into kind of everything that we do, including billing and all of the other kind of things that go into care. The last thing I want to just touch on is kind of some of the results that we're seeing with our program and how things are going. You all may know that retention in care for patients on medication-assisted treatment is one of the most important outcome measures there is. Particularly 180-day retention is seen as kind of the core quality measure defined by a number of groups. And traditional retention in care at 180 days on medication-assisted treatment, specifically buprenorphine, is in some published studies for Medicaid and commercial insurance around 35 to 40%. We're seeing about 70%, 75% for our patients at 180 days. And that's not just people who are still engaged, but people who are taking Suboxone for 180 days continuously. So this is a dramatic increase in people's adherence to treatment. Oh, do we have a question? I'm having trouble hearing you. Tyrone, do you have a question? Oh, maybe I guess he muted himself. Yeah, so anyways, this is dramatic improvement. And I think part of it, and other telemedicine providers of MAT are seeing similar results. So I can't claim that this is just, Ophelia being really great, but I think it's really the medium. I think the fact that patients can take their visits and get easy access to their medications wherever they are, without the barriers is really what's dramatically improving their ability to retain and care. And this is just kind of more of the same. And we also kind of track people's satisfaction with us. This is the Net Promoter Score is based on the question, how likely are you to refer or recommend this service to a friend or family member out of 0 to 10? And people, our patients and our clinicians really like us. So I'll stop there. I think there were some really interesting questions in the chat that we can start a dialogue on, but then open it up to anything else people have. One question from Victoria was, do you have platforms, like we don't have very good service or broadband in our area, do you have platforms for providers to have tech on site? I think it's really fascinating. And it's something that we've talked a little bit about. What would it look like to embed telemedicine access to local clinics, whether it's a community behavioral health center or just a FQHC that doesn't have an X-ray provider? Is there a room where you could put a screen and a webcam and then do a warm handoff down the hall to a telemedicine provider at Ophelia? Especially for patients who don't have smartphones, right? Which it could be really interesting. We haven't done anything like that yet, but if there was interest, we would love to pilot that with a group where there is interest. Just wanted to see if there was any additional thoughts on that thread before we address one of the other questions.
Yeah, I can jump in. So we have gotten offers before to have organizations provide telehealth MOUD services for us. So I work in work for a hospital. So we end up being the bridge organization a lot of times, which 3 days is fine, but more often than not, what happens is we start to bridge someone for 3 days. They work with our treatment coordinator, and then the treatment organization referring them to, especially because of COVID with social distancing capacity and stuff, we went from being able to get people in 4 days, so a 3-day bridge was sufficient, to now they can't take people for 7-8 days for an intake. So with the medical provider, and then our providers aren't always willing to write a 7-day bridge script because it's not like we're not having easy clients. Like we have clients who are coming in, getting bridge script from us, and then, you know, eloping and then coming back the next day and being like, sorry, I left a snort crack. Can I have more buprenorphine? And so our providers are only writing bridge scripts. They're not providing additional services. So they're not really comfortable doing that. So having someone who is comfortable, right, taking over that treatment would be great. But whenever we've tried to do that virtual service, we've always, whoever we've worked with has always needed like a nurse to check that person in or take their vitals or an extra level of care. And we, like every hospital, has been understaffed since the 60s. So we don't have an extra person for that. So I guess the question would be, what would be expected of us?
Yeah, so we do not require that our patients have an in-person exam before they join Ophelia. So it's easy for us to work off of that 3-day bridge. We aim to get all of our patients in certainly within a week of their outreach. I think 3-4 days is extremely reasonable for our providers and the bandwidth that we have. And we don't need nurses to do any supportive care at the front end, and we don't need any type of in-person eval before we can treat that patient. So we could easily work out a referral system where you ping us to let us know as early as possible that you've got a patient who's bridged, and it gives us that 72-hour window to get them into care with us. The other option is also just trying to get that patient connected to us before they leave so that they do their intake on site and we bypass the bridge process. They pick up their 1-week prescription with us the first day that they're with you guys.
And you all may know the reason that we're able to see patients without doing a physical exam is because during the public health emergency, the Ryan Haight Act has been suspended as a requirement of prescribing controlled substances. Previously, it required a physical exam in person. Now, it's a question of whether and when the Ryan Haight Act will be reinstated. And if it is, then the model that Emily was just talking about could still work, where an intake is done on site, patient has a physical exam, and then there's a warm handoff to a virtual service like ourselves, so that the physical exam requirement is met. But right now, there's no requirement for that. And so we would be able to kind of pick up where the emergency department or the urgent care leaves off. I think there was another question that was related of, would you work with someone who is also enrolled in our program? And then another question of whether we would be double billing. I wasn't sure what the second question meant about double billing, but as for like whether we would work with someone who's already enrolled in your program, we would. I think what we want to make sure of is that we can be in close coordination and communication. So because some patients do doctor shop, or they'll try and get Suboxone from multiple different doctors, and so we're obviously having all of our providers check the PDMP regularly, but we don't want to get into a situation where the patient is getting OUD treatment from 2 different doctors for the same medication. But we would absolutely coordinate care if you were providing primary care services and we were providing MAT services for the patient. As for double billing, I don't know what that question referred to, but we do bill insurance, but we only bill, if a patient's on insurance, we only bill the insurance. If a patient doesn't have insurance, then we only bill the patient for the out-of-pocket fee. We don't, if we're billing insurance, we don't continue to bill the patient as well, if that's what the question was asking.
One thing also, just going back to the idea of working with patients that are in your program, I think somebody alluded to this at the beginning. There are going to be patients that are really well set up for a telehealth platform, and in fact, are going to do better in a remote environment. And then there are patients that are going to really excel at an in-person environment. And so what I'd love to see is a way for you guys to use us as a resource to also free up space for you to really be able to tackle those patients that do require that in-person care. Because we know that there is a dearth of ex-waivered providers out there. We know that right now there is a workforce shortage across the board. And so for patients that you guys are seeing that, you think would do really well remotely, if we can build out a good system, within your program to work together to take some of those patients and give you more space, and then at the same time transfer over patients to you guys that we think would really benefit from some of the auxiliary services that you might offer, then we can sort of rotate back and forth with patients. And I could see patients also at times going back and forth, where there are times in their treatment where they really need, that more intensive in-person, and then times when the same patient is going to excel in a remote environment.
Yeah, I think that it looks like Leanne clarified, if a patient is receiving clinical and peer services at my program, can they come to you for MAT? And yes, absolutely. You can continue to bill for the services you're providing, and we can bill for MAT services for the same patient, because we're not offering the same exact service. John Bennett was asking about the process from our first online assessment to prescription. Basically, what that looks like is the patient goes through a brief screening survey, and they also fill out a pretty comprehensive medical intake form. We ask them their past medical history, medications, allergies, other comorbidities, medications they're taking. Before they come to their first visit, they undergo a 45-minute evaluation with a nurse practitioner or a PA, and we have a few MDs as well who are ex-waivered. And that person, first of all, clarifies that the patient meets criteria for opioid use disorder, that they meet criteria for MAT. They fill in all the other gaps in the understanding of the patient's history. And then they go over with the patient the risks and the benefits of the medication, how to safely store it, what the urine drug screen process looks like, and basically introduces them to the program. And then we prescribe the medication to the patient's local pharmacy. In the near term, we will also be offering for patients to have the medication shipped to their house. Some people have trouble with local pharmacies, but right now we're just writing scripts to their local pharmacy. And so patients will get their prescription within 12 or 24 hours of their first visit, as long as they're able to go pick it up. How long from first assessment to prescription? Yeah, it's, we'll write the prescription during that initial intake visit, and then the patient can pick it up right after the appointment, just like any other clinical visit. If an individual is already receiving, could you put in the chart the New York Medicaid HMO accepted?
Yeah, I'm working on getting that now.
And then does your staff include peer services? Yeah, so we're actually onboarding our first two peer coaches, we call them, in the next 2 weeks. And so we're going to be building up a program starting in February, where patients will have access to peer services.
There was another question earlier on, Ryan, I'm just going to flag it. John Bennett asked, could you talk about your process from first online assessment to prescription? So like, what does that look like, for the patient on the patient level? Sounds like, John, is that what you're asking?
Yeah, I think I tried to address that, but let me know if it wasn't clear. Anything else I can fill in there?
You got it. Okay, yes, thank you.
Okay, sweet. And then
also maybe real quick, as you're going through some of the other questions, Ryan, just to think about sort of what happens once a patient is moving forward with us. We have assessments to understand a patient's stability in care with us. We see them once a week. Usually around the 4-week mark, we transition them to biweekly and then to monthly after that. And at that point, they'll see a combination of the nurse care manager and their prescribing provider on a monthly basis moving forward. Obviously, if anything changes in their care, we bump them back up to a more frequent ratio of visit frequency if they need it.
One thing I wanted to ask you all about is how you manage referrals in your clinic systems. Every clinic and hospital I've ever worked in does referrals a little differently. Some send faxes, some, make the phone call with the patient, some, and we're trying to design a system to receive referrals in, as seamless as a way as possible for our partners and communities to make it easier for them. So I'm curious, if you were to refer a patient to treatment, let's say you're, in a clinic room with a patient, you say, I really think you would benefit from medication assisted treatment. There's this program called Ophelia. how would you go about, or what would be the easiest way to go about kind of making that handoff? Email. Okay.
I guess also, what has your experience been? What's your ideal? What would the easiest way be for you to do this? Okay, email for the win.
Yeah, and I guess, we're thinking about, we can accept referrals in different ways. As Emily mentioned, we have a care coordination team who processes everything that comes inbound. So we have patients who will send us text messages, they'll email us, they'll fill out the online form. And, I think what we want to design is a system that is easy and effective for providers, but also likely to engage the patient and lead to them actually signing up. Because oftentimes what happens with referrals is they get sent out and then it kind of goes into a black box. And then first of all, the provider never knows if the patient ends up signing up for care. And then the patient doesn't really have the information they need to feel like they can trust this other entity, right? And so, in many ways, like, it's very difficult, but a warm handoff from a provider where they call and talk to the care coordinator with the patient in the room on speakerphone could be a way of building trust. But we're also thinking about other ways to kind of get information to people that's effective, whether it's like a postcard about the program that the provider, as a primary care doctor, they could hand to the patient and say, hey, I think you might benefit from MAT. Here's a really great option with their website. And then like the key bullet points of like what the program is like and how it's different. We're trying to get creative and we want to design systems that work for providers rather than just kind of imagine solutions that aren't going to work,
Thank you guys for presenting. You guys are an amazing program, and I see this filling in the gap where people can't access more easily going into facilities. So my name is Crystal Marr. I'm the MAT director at Sun River Health. We have MAT providers across the 3 regions. And your question regarding how do we do referrals and all of that, we've had those barriers of providers being afraid to even open that door with patients, and we're constantly on that campaign, that stigma busting campaign. But the best way is like when we have identified somebody, it's like we get a lot of like street credit. I feel like street credit is key across the board in all 3 regions. But then the other way is through warm handoffs, whether it's warm handoff through the phone, virtually from one virtual program, just including somebody into another virtual program. And it might not necessarily be like once a provider, if it comes from internal where there's a provider, we don't really worry about the referral as much as we worry about getting them that appointment, getting them that medication. And then with some of the hospitals in different regions, participating in New York Matters has helped get a direct line into the programs, which has helped.
That's great. And that's also one of the things that I think, because we have such a robust care coordination team, it allows us to really focus on those warm handoffs. And I think for us, we will often, if we have an ROI and we're transitioning care, we can have both providers, on that call with the patient. Like we're really focused on making it as warm as possible. And so that's something we can easily have that care coordination team work with you guys on.
Mm-hmm. Yeah, and just having multiple points of access, whether it's through the healthcare system, whether it's through behavioral healthcare system, whether it's through the WASA system or what have you, I think that helps as well. Just having those multiple access points of care laid out. And I see you guys actually dovetailing nicely with Next Distro. That I love Jamie Farrow, who runs that. So
yes, absolutely.
She's like my hero out there we have her postcards all over the place within Sun River. I just try to make sure everybody knows. So, if you guys have those postcards, which have those informations, I definitely want them.
That's great. Yeah, we can
never own that program, but I feel like there can never be enough. So whichever way we reach people.
And we agree with that sentiment wholeheartedly. There can never be enough options for patients, and we don't always know what's going to work for patients. So having more options is better. And we can certainly get you guys flyers and things to distribute or to have in your waiting rooms to have patients have access to as well.
I think information for patients is really important. I think the other thing to add is that information for clinicians is really important as well. And thinking about like, you know, how we reach local community providers and let them know that we exist. It's one thing to have a conversation with people like you who are all bought in and understand the value of MAT. And it's a different conversation with kind of local PCPs, as you mentioned, who sometimes aren't ready to broach the conversation. And so some of it's about education and kind of, you know, changing practices, but some of it's even just about letting them know that we exist. And so Emily and I will certainly follow up with all of you after this conversation with some resources and the best ways to kind of send referrals. But I would also love to think about ways that we can further engage other providers in your community to let them know who we are and how the process works. So just a thought there.
I just put something in the chat. You know, I feel like this is a small little tasting of the services that are provided by Ophelia. We're really appreciative of your time. But, you know, if anyone here would like to learn more or would like to sort of imagine partnering and partnership with Ophelia in any way, definitely put your contact information in the chat and we will make sure that everyone gets it. And that those personal connections can be made, because, you know, this is just that surface conversation, but, you know, our hope and our, you know, our intent in putting these info sessions together is that it will just spark sort of a greater, those greater and more intimate conversations between organizations. You know, how might you see this, you know, this working for you and for the people that you're serving? So, so yeah, so feel free to just stick your information in the chat or just shoot us an email afterwards and just say, hey, you know, can we make a connection? But yeah, thank you so much.
So I just want to add something real quick. So I don't come from the treatment end of the spectrum, as Juanita knows. I am very firmly in prevention. And I know one of the biggest things that we see still on the community level is the stigma aspect of it. And so I really, really appreciate sort of some of the creative ways that you're thinking and talking about the stigma of getting treatment and getting into MAT. And so I really like how some of, you know, you spoke of like people being able to take their calls in their truck and, you know, driving down the road, talking on the phone is not, well, not handheld, obviously, is not something that is so random or weird anymore. And so I really appreciate that sort of aspect of it from the community level, because it does create this ability for someone to get into treatment without worrying. You know, many of the people in our communities are in small communities, right? Even though our counties may be large, but they know, you know, I in prevention, I used to sit across a parking lot from a treatment facility and you would see people walking in who you knew, right? And this gives them the opportunity to say, I want to share it when I'm ready to share it, not getting sort of caught walking through the door. So I really just appreciate that from the community level. And I think that that's something that if this is a way that we're trying to go, that's also a point of, let's say, information that needs to get out there, is to talk to the community members and really making sure that they know that this is an option for them, because many of them just, you know, when you're in that moment as a family member or a person who is in crisis, you see no options, right? And so really making sure that this is something they know is out there, I think is important. So thank you so much. I love the presentation.
Thanks. I think, you know, Jennifer, two of the things that you just mentioned, one is discretion, which is a huge part of why we started and why we exist. And we know how small communities work, and a lot of our clinicians come from small communities, so they get it. And it allows us to really have patients do this on their own terms and do this with privacy. And the other piece around stigma, which a few of you have brought up, and Crystal, you mentioned this as well, but one of the reasons why I think our retention rates are really good is not just the convenience factor. It's because we are a clinic that is entirely comprised of clinicians that actively want to do this work. And so They are non-judgmental, they are non-stigmatizing, they are the champions for this patient population. And so our patients get really good care because they get care from people that truly want to care for them. So, you know, that's another piece where when you feel like you're running out of options and the providers that you have, you know, the ability to make referrals to maybe aren't fully on board, you can use us as a tool for that. And then while we're doing the education for your providers as well, you know, and you guys are doing the hard work on the ground to get them to use non-stigmatizing language and all that, we can still get your patients into good care.
Well, thank you all so much for your time. We'll definitely follow up at the very least with information, and it looks like a lot of people have left their their emails in the chat, so we'll save those and follow up individually. But you know, one thing that I would love to explore further, if there's any kind of clinics that are interested, is this idea of piloting an on-site kind of digital room for handoffs. And we want to learn like what works well. And so if there's any clinics out there that would like to try that, we would be very keen. Otherwise, we'll share information and we can kind of take the relationships from there. And you guys are welcome to reach out to us anytime.
Yeah, and Juanita, we'll get names and contact info from you. Is that right?
Yeah, so we're compiling the list now. We'll certainly send it off. And I just, you know, we are, I am the project manager for Healing Communities for Ulster County. And so one of our strategies, our community-led strategies, was to develop health access rooms. And so we do have some sites actually on here right now, like the Hudson Valley Veterans Reintegration Center, who actually has a telehealth room that they have, you know, dedicated for this really specific purpose. So, you know, all of these folks, we do anticipate connecting you. So that is something that we would like to also explore with you. So we look forward to keeping that communication going and connecting you closer with our telehealth. We have, I think, 3 in the county that we've deployed. So, yeah,
That's exciting. That would be really fun to build out with you guys.
yeah, for sure.
Great.
So yeah, so we'll keep in touch for sure, and share everyone's contact information. Thank you all so much. There's certainly a lot of interest. So we appreciate your time, and you know, we feel like these connections are just going to build our community's capacity to serve folks. So thank you. And we have recorded this, so we will be sharing it.
Great. All right.